Hi, my name is Rishi, and I'm honored to speak to you all virtually. Our project is called Abacavir Antiretroviral Therapy and Indices of Subclinical Vascular Disease in HIV and AIDS. An estimated 35 million deaths have occurred since 1981 due to HIV. The advent of antiretroviral therapy has prolonged survival of people with HIV to near seronegative counterparts. Thus, antiretroviral therapy is now recommended for all people with HIV, regardless of CD4 levels. Despite improvements in survival rates, people with HIV have a 61% higher cardiovascular disease risk compared to HIV-negative individuals. To date, the etiology of the increased cardiovascular disease risk in people with HIV is unclear. However, the heightened inflammatory state caused by HIV, as well as the adverse effects from antiretroviral therapy, have been postulated. Several studies have found abacavir to be associated with elevated cardiovascular disease risk. In 2008, Sabin published findings from a prospective observational study of more than 49,000 people with HIV that showed subjects with recent use of abacavir had a 90% greater rate of myocardial infarction. However, there was a potential for confounding, as abacavir has historically been used in patients with already elevated cardiovascular disease risk, as abacavir has not been shown to cause dyslipidemia or insulin resistance. The SMART study validated the findings of the DAD study. Patients who received abacavir compared to patients who received antiretroviral therapy not including abacavir had almost twice the cardiovascular disease risk. Additionally, higher levels of high sensitivity C-reactive protein, as well as IL-6 levels were found, which are markers of inflammation. Another source of bias in the above studies was the preferential use of abacavir in patients with chronic kidney disease over tenofovir, which has known kidney complications. This brings us to the VA study, which controlled for chronic kidney disease and still found that abacavir was associated with elevated cardiovascular disease risk. Since then, there have been several observational studies, randomized controlled trials, and meta-analyses that have shown no statistical significance in cardiovascular disease risk with abacavir. The vascular endothelium plays a crucial role in maintaining circulatory homeostasis, controlling vascular tone, to ensure appropriate blood flow to tissues, conserving the balance between nitric oxide and inflammation. Measures of vascular function include flow-mediated dilation, endothelial progenitor cells, and arterial stiffness. Our study had two main aims. The first was whether group differences in vascular function outcomes are observed in people with HIV on stable antiretroviral therapy, compared with HIV seronegative individuals. The second was whether group differences in vascular function outcomes remain when controlling for demographic variables, prescribed medications for comorbid conditions, and substance abuse. Our study took place at the Special Immunology Clinics at the University of Miami, Jackson Memorial Hospital, and data was gathered in a single vascular function assessment session. In order to assess vascular endothelial function, we measured flow-mediated dilation. Data has shown that a 1% decrease in flow-mediated dilation is predictably associated with a 13% increase in cardiovascular disease. The figure on the top right shows how cuff inflation, seen on the x-axis, leads to dilation of the brachial artery diameter, shown on the y-axis. We also assessed arterial stiffness via pulse wave velocity at the femoral and radial locations, as seen in the figure on the bottom right. We measured EPCs via venous blood draws. There is established evidence that reduced availability and impaired EPC function is associated with cardiovascular disease risk. Here are results depicted in Table 1. We can see that there are 28 individuals in the abacavir group, 39 individuals in the non-abacavir treated group, and 48 seronegative individuals. At the top of the table, we can see that sex and ethnicity had no statistical significant difference among groups. However, people with HIV were older and had less years of education. In the middle of the table, we can see that there was no statistical significance in BMI. However, people with HIV did have higher triglycerides. There was no statistical significance among groups regarding drug dependence. And towards the bottom of the table, we can see that the Bacavir treated group had higher use of antihypertensives and statins. Lastly, at the very bottom of the table, we can see that there was no statistical difference in HIV duration, CD4 count, or viral load among groups. The next table illustrated subclinical cardiometabolic measures of the groups when controlling for demographic variables, prescribed medications, and substance abuse. At the top, we can see that there was no statistical difference among the groups in BMI, waist circumference, insulin resistance, and CRP. The non-abacavir treated group had a statistically significant worse lipid profile, and people with HIV had a higher heart rate. Towards the bottom of the table, we can see that pulse wave pressure and max velocity, which are the measures of arterial stiffness, were higher in the non-abacavir treated group. Additionally, EPCs were overall lower in the non-abacavir treated group. HIV is known to cause injury to the endothelium, and flow media dilation has been used in studies to assess for endothelial dysfunction. A case control study by Sharma assessed for endothelial dysfunction in people with HIV and found a statistically significant impaired flow media dilation among people with HIV. Flow media dilation has also been used to assess endothelial function in people with HIV treated with abacavir. Su found a statistically significant decrease in flow media dilation among people with HIV on abacavir. Conversely, in a cross-sectional study by Wool, the authors used FMD to assess cardiovascular disease risk in people with HIV on abacavir versus tenofovir and did not find any statistical difference. Our study echoed these results in not finding a statistically significant difference in flow media dilation among groups. Studies have used measures of arterial stiffness to assess cardiovascular disease risk in people with HIV. Shikali used pulse wave velocity to measure aortic stiffness in people with HIV not on antiretroviral therapy and found a statistically significant increase in pulse wave velocity in people with HIV. In a case control study, Van Vonderen found increased arterial stiffness in men living with HIV. In another study, a prospective study by Sen, it was found that by switching from abacavir to tenofovir, it resulted in a decrease in arterial stiffness. Conversely, our study found that people with HIV not treated with abacavir displayed greater arterial stiffness in radial and thigh circulations, and this will need further research. Several studies have found correlations between reduced EPCs and people with HIV. De Silva performed a case control study of people with HIV not on antiretroviral therapy compared to healthy controls and found a statistically significant reduction in EPCs among people with HIV. To our knowledge, our study is the first to assess for the effect of abacavir on EPCs in people with HIV. In our study, EPC levels were comparable among groups, although overall less in people with HIV not treated with abacavir. Our study had a few limitations. One was that our study was cross-sectional, preventing cause and effect type conclusions. Also, our cohort was comprised mostly of Hispanics of low socioeconomic status, but this was representative of the local community. Lastly, our cohort was younger than other cohorts mentioned in prior studies. However, we were one of the few studies to control for both cardiovascular disease and diabetes. In conclusion, HIV is a chronic disease, and understanding cardiovascular disease risk is paramount. Our study was well matched and did not support the hypothesis that abacavir treatment contributed to elevated cardiovascular disease risk. These findings were independent of demographics, medication use, and substance abuse. Our study was supported by Gilead Sciences and Miami Centers of AIDS Research. I would like to thank the Miami CFAR team, co-investigators, and study staff. Additionally, special thanks to my mentors, Dr. Martinez and Dr. Horowitz. Thank you.